Hey, DNA. Kate Wilson here with another episode of All Access DNA. In today's episode, we are talking to Jeri Nichols about pharmacogenomics. Studies indicate that more than 98% of people have a genomic variant or change that can impact how they respond to commonly prescribed medications. So some may respond better to a lower dose of medicine, while others respond to a higher dose. Jeri is a pharmacogenomics expert who blends over 2 decades of experience as a pharmacist and genetic counselor to revolutionize personalized medicine. Jeri founded Gene Farmer LLC in 2021, a consulting practice that empowers patients with safer, more effective medication regimens and often reduces reliance on unnecessary drugs. Let's get started. Welcome, Jeri. It's so good to have you on the show today.
Hi, Kate. Thank you very much for letting me join you. I appreciate that.
Yeah. So we wanted to talk to you about pharmacogenomics, but I definitely want to start at the basics, and partly because this is an area I'm not as familiar with. What is pharmacogenomics and why should the average person care about it?
So just the term pharmacogenomics, I think, sounds kind of scary to some people. It's a very big word, but essentially it just means studying how a person's genetics influences their response to medications. And so it may be that they respond as expected to a medication based on their genetics, or it could be that a medicine simply doesn't work for them, or it may cause them, side effects or an unwanted reaction, essentially. So pharmacogenomics, as a shortened word, a lot of us will just use PGX to refer to it. But again, It's just talking about how somebody's genetics influences their response to medications.
Okay.
And as far as why the average, so for why the average person would care about pharmacogenomics or genetics is that most people at some point in their life take a medication. As we get older, we tend to take more medications. If you look at individuals who are over 50 years of age, I think it's 30% that take 4 or more medications. Those that are over 65, it's probably around 50%. But even if you look at adults who are under 50, around 10 to 15% of them take 4 or more medications. And a lot of these common medications are ones that we have data for so that we know how a person's genetics may influence that medication. And having that information can then lead to better prescribing, whether it's changing to a different medication or possibly just adjusting the dose of the medication so that it is better for that particular patient.
Okay. I mean, it sounds like it can be extremely informative, especially as you said, quite a few folks are at least on some type of medication. I know some common ones that I've heard about in terms of PGX is antidepressants, painkillers, blood pressures, medicines. How exactly does our genes influence how we respond to these types of medications?
Okay. So taking painkillers, for example, that's a really good one because you have both prescription medications that treat pain. A lot of people would think of like the opioids. And then you have over-the-counter medications that can treat pain. So you've got Tylenol, ibuprofen, naproxen, aspirin. And there's actually very good genetic data for ibuprofen in particular. So there's a gene called CYP2. When we're talking about a gene, we're just talking about something that makes a protein. It creates something in the body. So what the CYP2C9 gene does is it creates an enzyme, and that enzyme has a normal function in our body, but also if we take in things from the outside world, such as ibuprofen, that enzyme is supposed to break that medication down to help clear it from the body. If you make a normal amount of CYP2C9, then you probably have a normal response to ibuprofen. If you have a low amount of CYP2C9, or in some cases absent CYP2C9 enzyme, you either break down ibuprofen slowly or potentially not at all, causing that medication to have a much longer lasting effect for a person, which can be good in treating pain and inflammation, but it can be bad in terms of it leaves you exposed to that medication longer. So you're at higher risk of the side effects from it, such as it causing bleeding or causing high blood pressure, something that you're not wanting that medication to do. And then if you look at prescription pain medications, codeine and tramadol are 2 really good examples of opioids or opioid-like medications where the medication itself doesn't have properties that treat pain. So instead, the body needs to convert codeine or tramadol into something that is able to hit on those pain receptors. And there's a gene called CYP2D6 that makes an enzyme, CYP2D6, that converts codeine and tramadol into their active metabolite. So if you're a normal metabolizer, again, you may respond well to codeine and tramadol. But if you have a variant in your CYP2D6 gene that makes you make less of that enzyme or none of that enzyme, then again, you're not converting codeine or tramadol. So you're not getting the pain relief from the medication that you would expect. In that situation, it can unfortunately lead people to doing what they shouldn't, which is taking more of the medication than prescribed because they're trying to get pain relief.
Right.
And so in some ways, thinking about the opioid crisis, having genetic information could potentially help prevent some individuals from going down that path of an opioid type dependency.
And the medications that you have mentioned or used examples of, I mean, they're not uncommon, right? But I don't think PGX testing for those medications is common because I'm thinking about like doctor's appointments I've had or family members have had. I don't think anybody's been offered any type of testing. So is the testing routinely offered, or does it usually happen when somebody, like you said, isn't feeling the effects of the medication and goes to their doctor and then maybe gets a workup there?
Yeah. So unfortunately, while pharmacogenomic testing itself is fairly available, there are lots of labs around the country that do the testing. It's not something that's frequently offered to patients or ordered, even when patients are having issues with medications, the side effects or the medicine not working. Most prescribers don't offer the testing unless you're in a center that already has kind of a pharmacogenomics program going and has pharmacists or sometimes genetic counselors involved in that program and offering testing to patients. There are some places that are really good about doing testing. St. Jude's is one example. So it's a pediatric hospital, and I think that they offer pharmacogenomic testing to most of the patients who come through there. And some of that's for informing prescribing related to cancer.
Right. And I think that's probably where I've heard of some of like at least the guidelines or recommendations are in cancer treatment medications. And from what I understand, that type of testing may help people avoid like side effects or allergic reactions. So how can this type of testing help people avoid those, those ill side effects or just kind of going through this trial and error process?
Yeah. So if anyone hasn't heard one of your previous episodes, I would definitely recommend that they go back and listen to the one that Karen Merritt was on, where the discussion was primarily around DPYD. So again, it's a gene, it makes an enzyme, and this enzyme is particularly important to breaking down what are called fluoropyrimidines. And that is something that is a medication that's used to treat like a lot of colon cancers, metastatic breast cancer. It's used for some other cancers as well. And there are individuals who make none of the enzyme, and giving them that particular chemotherapy can be deadly. So knowing in advance that you have that genetic change could mean either avoiding the medication or using it at a much lower dose to try to prevent those horrible side effects, including death, that can come with that medication. So yeah, a lot of times when we're talking pharmacogenomics, we're talking about avoiding side effects or getting a therapy that works. But sometimes we're actually talking about potentially avoiding death because of the body not being able to break down and clear a very toxic medication.
Yeah. And I think what was so interesting in talking to Karen is that we know that this testing can help people avoid death and severe side effects. And it still doesn't seem to be part of routine testing. I think some places are better than others about doing it, but it still is one where there have been people that have been missed and never had the DPYD testing.
Yeah. And some of that, I think, is a lack of knowledge that, even when I've talked to people who've worked in the oncology space for years, they may be unfamiliar with DPYD and that deficiency and what that can look like. And, unfortunately, for such a long time, it's been accepted that chemotherapy is frequently toxic. It causes a lot of horrible side effects for patients. And so I think that unfortunately, individuals that are dealing with toxicity because of a DPYD deficiency, a genetic deficiency, it can even go undiagnosed because chemotherapy causes bad side effects. And that's just how it's kind of looked at. But the reality is this is one particular one where having that genetic information in advance could save lives. And not just save lives, but it can also save money.
Mhm.
if you don't have people hospitalized for a series of days, weeks, dealing with the side effects of the medication.
Right. For folks that are taking kind of just daily more common medications, so not necessarily for like cancer treatment, and they've been taking it for years. So say like an ibuprofen or codeine or some of these other ones that you had mentioned, and they haven't had any issues. Like it seems to be working. There doesn't seem to be major side effects. Is there still value in getting tested? When is this PGX recommended?
Yeah, I would say there's definitely still value in testing. I mean, I can give you a perfect example for that. But as far as when it's recommended, in my opinion, I think that everybody should be offered PGX testing. Even if you are not taking any medications at this point in time, just having that information in a way is sort of like an insurance policy. So you have it available to you when you might need it at some point in the future.
Mhm.
Again, DPYD being a perfect example because sometimes people get a sudden cancer diagnosis. And there's urgency to get
Right.
chemotherapy started. And, a PGX test, as with a lot of genetic tests, might take a week or two to come back. And maybe they aren't wanting to have to wait, to
Right.
start
Right.
therapy. Or if somebody has a heart attack, for example, and they have a stent placed, they're often put on a medication called clopidogrel. Plavix is the brand name of that. It's an antiplatelet drug. And so the idea is that it will prevent the platelets from getting sticky and from sticking to that stent in the heart so that they're less likely to have a recurrence of a heart attack.
Mhm.
The problem is that clopidogrel itself doesn't have antiplatelet activity. So again, there's an enzyme in the body, it's called CYP2C19, that has to convert clopidogrel to its active metabolite that can then have that antiplatelet activity. And so those patients are being put on it while they're in the hospital. There's no waiting for a genetic test to come back.
Right.
But if you had the information ahead of time that you were a poor metabolizer, for example, which is common in Asian populations. So
Hmm.
if ahead of time you were a poor metabolizer, then clopidogrel is not even something that would be prescribed. You would want to use a different antiplatelet medication. So that insurance policy, would kind of pay out there. But one specific example that I can think of is a patient that we did pharmacogenomic testing on, and it sort of explained this process of things that happened to them. So many, many years ago, a patient, she had a lot of like sinus congestion at night and found
Mhm.
that ibuprofen seemed to be the only thing that really helped. And so she was taking
Hmm.
like 400 milligrams of ibuprofen every night, and it seemed to help with the pressure. And after several months of doing this, she had a lot of fatigue, was just tired all the time. They did some blood work and she had pretty low hemoglobin. So they ended up doing an upper endoscopy, and she had so upper endoscopy being, looking into the esophagus and the stomach. And she had some kind of ulcerations in her stomach. In other words, some
Hmm.
irritations, some areas that had probably been having some bleeding. And they decided, well, this can be a side effect of ibuprofen. So stop the ibuprofen and then
Mhm.
put her on omeprazole. Omeprazole is a common PPI, proton pump inhibitor. It's available over the counter. You can also, get it by prescription. And what the omeprazole does is it reduces stomach acid. So it helps those ulcerations to heal.
Mhm.
The problem is she was left on omeprazole for, I think, a decade or more.
Wow.
And this unfortunately happens a lot. So, one public service announcement that I would have for anybody listening to this podcast is if you're on a proton pump inhibitor, so that could be omeprazole, Nexium, pantoprazole, lansoprazole, those kinds of medications, talk with your doctor about whether you really need to be on it. Because a lot of people are put on it for a short-term problem and then they're just
Right.
left on it for years.
Right.
And it's one of those things where you think, oh, I'm fine. You don't really notice issues. But
Mhm.
proton pump inhibitors can cause, because they decrease your stomach acid, they can cause problems with absorption of nutrients, absorption of calcium. So long term, you're at higher risk of osteoporosis. You're at higher risk of gut infections, things like that. So what happened with this patient was she stood up one day, heard a snap, and fell to the floor.
Oh
Her
my gosh.
femur spontaneously broke.
Oh my gosh.
Yeah. And when we did her genetic testing, what we found is that she was a CYP2C9 intermediate metabolizer. So that means she had lower amounts of that enzyme than expected. And so it kind of explains why the ibuprofen worked well for her because she was clearing it more slowly from the body. But it also
Ah.
probably explains why she likely had that ulceration going on because the ibuprofen was hanging around longer, so putting at her more risk for those issues. Well, then she was prescribed omeprazole because of what happened with the ibuprofen. She was also a CYP2C, so another enzyme, intermediate metabolizer. So again, making less of that enzyme. It's the enzyme that can break down omeprazole and help clear it from the body. So for her, omeprazole also lasted longer, worked better, but had that potential for more side effects, including being at risk of fractures, spontaneous.
Mhm.
So had she had the genetic testing many years prior, before taking ibuprofen, before taking omeprazole, the dosing would have been done different, or an alternative medication would have been chosen for both the ibuprofen and the omeprazole.
Right. Oh my gosh. I mean, I didn't even know that was a thing that could happen with the spontaneous fracture of a femur. I mean, that's a huge difference that knowing this information would have had. And so I am sort of surprised that it doesn't seem more commonplace given the potential impact it can have.
Yeah. Yeah. And that's part of why I'm passionate about it, because I've seen over and over, in testing and working with patients, that even if you don't go into the test expecting some benefit, like usually there's information there that
Right.
could
Right.
help you either explain something that happened in the past, something that's going on now, or give you guidance in the future.
Right. And you've told us a few different stories about kind of the impact pharmacogenomic testing. Are there any other ones that you can think of where it made a significant difference in somebody's treatment or their health outcome?
There are a few. So I've got multiple patients that I can think of who were struggling with like depression and finding a medication that would work for them and not cause side effects. And in all of these cases, the patients were CYP2D6 poor metabolizers. And once you had that genetic information, like it very well explained with the different antidepressants that they had tried, why those antidepressants caused them side effects. And then it helped guide to one that would be more likely to be beneficial for them. And in some of the cases, these patients, because they had tried multiple medications and sometimes had really bad side effects, it made them very hesitant to try anything else to treat their depression, which is kind of unfortunate because then they're just dealing with untreated depression and can have additional anxiety and depression essentially layered on top of that because of the difficulty with finding a good treatment. So, yeah, definitely with antidepressants, there seems to be a lot of potential benefit with medication
Yeah,
guiding you
'cause
towards something.
and I think that's one thing that can be frustrating, and I will say speaking from personal experiencing, is try to again, that trial and error. So just continuing to, like, go through a laundry list of medications, try it for a while, cross it off, and so it sounds like that pharmacogenomic testing could help either eliminate the trial and error or significantly reduce kind of the list of medications to go through.
Yeah, yeah, it definitely can. And depression being a little bit different from like treating pain or treating high blood pressure, where with those two, generally after a couple of days to a week, if the ibuprofen's going to work or if the hydrochlorothiazide you're using for your blood pressure is going to work. Whereas with depression, patients are typically told you need to give it 6 to 8 weeks to see how you're going to respond.
Right.
Which means if after 6 to 8 weeks you didn't respond or you had problems with it, then you move on to a new medication and you get to do that whole 6 to 8 week thing over again.
Right.
And once you've done that 2 or 3 times, a lot of patients are just ready to be done trialing medication.
One question that I had, again, this is not my area of expertise, is the accuracy of the testing. So, I guess how accurate is it? What are the limitations that people should understand about PGX testing?
Yeah, that's an excellent question and sometimes a little hard to define. So, the accuracy of the test itself for what it's looking for is going to be very accurate. I would not say 100%, but probably 98, 99% accurate. And when I say what it's looking for, pharmacogenomic tests, some labs may test for a dozen genes, and they may be primarily these CYP genes that I've been talking about. And then I have seen other labs that maybe test for 3 or 4 dozen genes. So they may
Mhm.
test for, these CYP genes and the DPYD and then other genes that maybe don't make enzymes that make the receptors that the drugs target.
Okay.
And so in part, how accurate a test is or how beneficial it is to the medications the patient's interested in depends on what genes the lab is looking at. But
Mm.
the other thing to keep in mind is that the majority of labs are not reading a given gene or sequencing it from one end to the other. If they were, then you would expect they would find any variation within that gene. Instead, what they're doing is a very targeted test where for one given gene, maybe they're looking for 5 different variations in that gene. And those 5 variations might account for, 90% of the variations that are in that
Hmm.
gene. But there may be 600 other variants that can happen that only 10%, of people may have or less. So it is possible that you can do a pharmacogenomic test and it could tell you you're a normal metabolizer for a particular gene or enzyme. And that may be incorrect. I mean, the lab interpreted it correctly based on what they looked at. But if they
Mm.
were able to actually sequence the gene, they might find a rare variant that says, oh, no, you don't even actually make any of this enzyme. And there are studies that I have seen where they have compared populations that did just the genotyping or the targeted testing to sequencing, where you're reading from end to end. And what they find is that around 10% of patients have a variant that is missed in that.
Wow. Okay. So I guess it's all tests are not necessarily created equal or look for the same thing. So how would a person know if they're getting the right test for them? Right? Because there's quite a few on the market, especially in some of these direct to consumer types of testing. So not through necessarily like a larger diagnostic lab that your doctor would potentially order through. How can a consumer know that they're getting a test that will be the best fit for them?
I think on their own, for most consumers, that's going to be a really hard thing to determine. Your better bet is going to be talking to a pharmacist, a genetic counselor, physician, a nurse practitioner, somebody that is well versed in pharmacogenomics that can look at what lab you've used or what lab you're wanting to use, what genes are they looking at, what variants within each gene are they looking at. There are actually guidelines from AMP, Association of Molecular Pathology, I think is what it stands for. I kind
Yes.
of blanked on that. So AMP, in conjunction with multiple other associations, have
Mhm.
created guidelines for a lot of the common pharmacogenomic genes to say, if you're going to test CYP2D6, for example, these are the minimum number of variants that you should be looking at. And these are some of the like nice to have variants, on that panel. And they've done that for several genes. And I know, some of the direct to consumer things may report on pharmacogenomic genes, but they usually are reporting on 3, genes maybe, and maybe only 1 or 2 variants within each gene.
Mhm.
So that makes it a lot easier to get a wrong interpretation, to be assigned a normal metabolizer phenotype, for example, when you're actually a rapid or a poor metabolizer. And it's because the direct to consumer test does not look in the same depth that
Right.
those clinical labs do.
Right. Okay, that makes sense. And is the test covered by insurance? So living here in the US, that's always one question I think that all of us have, especially with genetic testing.
Yeah. And that's a difficult question to answer because they should, in a lot of cases, cover the testing. Whether they do
Right.
or not becomes another issue. So, Medicare will generally cover pharmacogenomic testing if there's a drug gene pair that the patient's being considered for, and that there is, FDA information on this drug gene pair, or there is a CPIC guideline. CPIC being the Clinical Pharmacogenomics Implementation
Mhm.
Consortium. So they write a lot of the pharmacogenomics guidelines that are widely used across the US and actually across a lot of the world. So if there's a FDA information or CPIC guideline for that drug and gene pair, then a lot of times Medicare will cover the testing, as long as that's like not the primary or the only information, I guess, being used to prescribe for the patient.
Right.
But yeah, the experience has been that for Medicare, a lot of times it can be covered. Some other commercial insurances will cover pharmacogenomic testing as well, using kind of
Mhm.
similar guidance. Cash pay is also, an option for some individuals. Most labs that I have looked at will charge somewhere between 250 and 500
Mhm.
cash price for a pharmacogenomic test. And of course, one thing to think about with a pharmacogenomic test is that it's information that you can use for years down the road. So it's
True.
different than having your blood drawn and having a CBC to look at your white blood cell count or your red blood cells, or a hemoglobin A1C to see, how well controlled your diabetes is. Those are things that change, day to
Mhm.
day, month to month, year to year. But your genetics, you're born with your genes and they don't change,
Mhm.
from
Mhm.
one year to the next, typically. Mutations causing cancer kind of being an exception there, but, you know, your genes don't change. And so the interpretation of a gene or a variant may change. And so you may need to look at a report that was done 5 years ago to see, okay, the way that this was interpreted then, does it still apply now? And I
Mhm.
wouldn't say you never have to repeat a pharmacogenomic test, But if you put in $250 to $500 investment into that lab, you're going to be able to use that information for several years before you would ever have to leave it.
Yeah. Yeah. Well, and I think that's partly too, like being able to talk to physician, genetic counselor, whomever, is if you have it done, then every so often you can have them look at it, review it, see if there's anything that's changed in the interpretation. I noticed that you had mentioned about pharmacists, but we've also talked about like oncologists and other types of specialties that still are kind of learning about PGX. What role do pharmacists play? And is it something that you think is common knowledge yet with pharmacists in terms of PGX?
It's definitely becoming, the knowledge is more widespread now than it used to be, or at least the
Mhm.
awareness, I guess I should say of pharmacogenomics. It's not, so I entered pharmacy school in 2010 when I left
Mhm.
genetic counseling to change professions. And at that point, pharmacogenomics was not being taught, at least not where I went to school and not at most pharmacy schools around the country.
Mhm.
Now it is supposed to be part of the curriculum, but it's not well defined. So how much a given pharmacy student is learning varies, from one
Mhm.
pharmacy school to another. But they're being made more aware of it than what pharmacists who've been practicing for a decade or more would have been taught. And so, a lot of pharmacists who've been out there working for a while are going to have to take some kind of a training certificate, to learn about pharmacogenomics or just kind of do some self educating. But pharmacists are definitely, well, I'm probably biased, but feel like they're sort of the go-to health professional for pharmacogenomics
Mhm.
because, a lot of labs will give you a report that'll be sometimes a couple dozen pages long. So it
Mm.
lists out all the patient's genetic information, whether they're a normal metabolizer, poor metabolizer, et cetera. For each of those genes, they'll have lots of information about the various medications that someone could take and often put them into like red, yellow, and green columns. So, like
Mm.
green
Mhm.
being, it should be okay to use this medicine. And
Right.
red is like you want to avoid it or use with extreme caution. And then yellow, is kind of somewhere in between. And if somebody isn't well versed in pharmacogenomics and what the genetics and the medications, like how those really interact, I have heard of patients who were doing well on a medicine that was in the red column. And their doctor took them off of it after the PGX test because they were like, oh, well, this
Mm.
says it's in the red column. You shouldn't be on this medication. And that's not necessarily the case.
Mm.
So the pharmacist can really take into account the patient's medical history, all the medications that they're on, what their comorbidities might be, what's their kidney function, their liver function, in addition to what do their genetics say. And so they can make something much more personalized to the patient than what that lab report says for the patient's given
Right.
situation.
Right. Oh, that's a good point. I think looking ahead, because it seems like there's been tons done in pharmacogenomics, because like you said, I think 2010 you're talking about in pharmacy school. I know when I trained in genetic counseling, this was a while ago. So we didn't have much exposure to PGX. How do you think it's going to impact healthcare providers and the way they prescribe medications over the next 5 to 10, 15 years?
I mean, I feel like it's eventually going to get to a point, and I really hope that it gets to a point, that prescribers are no longer prescribing without having the pharmacogenomic information, but obviously as long as the patient consents to wanting that information. It's going to allow patients better outcomes. Like we've talked about, less trial and
Mhm.
error. It's potentially going to save money too. It'll save money, in emergency room visits, hospitalizations. It's going to allow people to be more productive, less missed days of work. So there's things beyond the individual, we would want to do it for ourselves for kind of
Mhm.
selfish reasons, obviously, but there's potentially a much bigger global impact that pharmacogenomic information could have. One of the really big challenges we have right now, though, is getting the information into a usable form.
Mm.
So, I do pharmacogenomic testing for my patients, and then I provide them a copy of the PDF so that
Mm.
they always
Mhm.
have that report. But it doesn't then get into every single healthcare system that they're seen in
Right.
and every doctor that they're seen in. And so, and even if it is, a lot of the electronic health systems are not set up, the records aren't set up to like flag or alert,
Right.
if a patient's had testing. And then you have the whole separate issue of retail pharmacy, which is
Mhm.
where I worked for several years before kind of delving into pharmacogenomics. And retail pharmacies are typically separate from any large health system. You're getting prescriptions from outside doctors. And so you can't see that patient's labs. You don't have any way to know if they've had
Right.
genetic testing done, or if they had, how would you use that information in a retail setting to try to be a double check,
Right.
that what was being prescribed is appropriate. So, yeah, we've got a very siloed and kind of fragmented health system that makes it hard to
Mhm.
implement innovative things like this.
Yeah. Yeah, and then like you said, like sometimes they're gonna get dozens of pages back, and then they also still need that interpretation or personalized interpretation or kind of how it fits together with everything. So sounds like an opportunity for folks to think about how do we integrate that? Could we use AI, some other types of systems maybe to kind of pull in all these data points and streamline it in a way so that we can then offer it broadly to
Mhm.
a lot of folks. But it is challenging, especially like you mentioned with the silos between kind of the pharmacy, the treatment areas, and then, many people are seeing more than one physician at different practices.
Yep, definitely. And
Mhm.
and that's one of the things that's very challenging in the retail pharmacy, because we get to see all those prescriptions that come from 5 different doctors. But
Right.
those doctors don't necessarily talk to each other, and so it's up to the patient to be giving the information and telling the doctor everything that they're taking.
Right, right. Well, Jerry, like I said, I really appreciate you being here. I have learned a ton and honestly could probably chat with you some more about a lot of these things. And I appreciate the way that you explained everything as well. So again, just thank you so much for being on the show today.
Yeah, thank you, Kate, especially for giving me an opportunity to talk about one of the things I'm very passionate about, and would definitely like for more people to know about pharmacogenomics and how it can help them.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening and join us next time.